Good afternoon, everyone, and welcome to the Royal Hospital for Neuro-disability, the lunchtime public lecture. So very welcome to all. I am Dr Andrew Hanrahan, and I work at the Royal Hospital for Neuro-disability in Putney in London. As you can see, I'm part of the brain injury service, the level 1 service. I contribute to the neurobehavioral service, but I'm also the clinical end-of-life care lead for the organisation, obviously in neuro-palliation as opposed to a classic palliative care specialty attached to a hospice. So our mission statement is very clear. It's just meeting the complex needs of people with profound disabilities, whatever those needs might be at the time of their injury or as they grow older with an injury, for assessment, or indeed while they approach the end of their lives, dying and death from their injury or otherwise. We have a bit of history over here, and that takes us back to some of our original patrons in the early 1850s when the Reverend Andrew Reid set up the organisation as a Victorian philanthropist. It is an extraordinary fact that among the innumerable medical charities with which the country abounds, there is not one for the help of those who, for all others, must require succour, and who must die, and who die in thousands, neglected and unaided. So this was for the Incurables, which was the Royal Hospital and Home for the Incurables, a charity started by the Reverend Andrew Reid. And the mission statement, as it were, is if we cannot heal all, as indeed we can't, we must soothe, help and comfort all, and to the last. I cannot endure that any sufferer of the human family should be excluded from human sympathy. So both from Dickens and from Reid, a very Victorian flow of prose, eloquently explaining what it is that this organisation did in that generation. As we are a charity, we're run as a social enterprise, and we must respond to the social needs of the generation we live in, and an enterprise where it is a not-for-profit organisation. Now, our current services, what mandates myself to talk about this, or indeed be employed here? And that is because we have a large sum of neurological disability on one site, not particularly under one roof, but on one site. As you can see, there are about 230 patients or residents on site, and they are dispersed around these various service domains. And for many, in fact, in the specialist nursing home, 126 of them, all of them on the ventilator unit, 32 of them, in the young disabled unit, all of them, bar those on the neurobehavioral and the level 1 unit, this is their home. So this is where the postman calls. We have a large element of burden that goes with that, if I can refer to it that way, and that is in terms of space, equipment, plastics that could be in the form of feeding tubes, 186 of them as of last week, 70 odd tracheostomies, 32 ventilated patients, and moving away from the biology of their injuries, very few of them are actually able to consent to their placement here. So the entire legislative framework in terms of deprivation of liberty safeguards, liberty protection safeguards needs to be gone through. Wheelchairs is another piece of equipment that you will see attached to almost all of our patients. And the 2% who don't have them are either bedbound and in whom wheelchair access is actually not in their best interest or contraindicated. So there are a few patients on the brain injury service who have a backup wheelchair, but who otherwise be ambulant. Now, in this short talk, I propose to go over these areas, and hopefully there'll be enough time for questions and answers at the end. I've left some. And brief definitions of what we mean by neuro-palliation and palliative care. What is the role of palliation in neurological disorders? How do we recognize the need for it? Who should be doing it? What is it? And at a local level, what are we doing at the RHN? Nationally, what do we expect? And bearing in mind that this is a problem across all levels of community, tertiary care, secondary care, that we have people with neurological diagnoses, but also with neurological disability. Now, the common principles in all these conditions, and believe me, they are protean, and each condition behaves differently at a different point in time in different persons, but the basic guideline principles are the diagnosis. We have to be secure about a diagnosis, look at its clinical aspects, have the skills to treat, the skills to care. What is the prognosis within this diagnosis? Sometimes there are many diagnoses. How do prognoses then interact with this multitude of diagnoses? A common example would be somebody in a disorder of consciousness from a sentinel traumatic brain injury, but there might be a serious mental health diagnosis in the background, cardiovascular comorbidity, alcohol, and a few more pathologies thrown in. The person, we never lose sight of that, the authentic narrative of that life, whether capacity exists or not, whether consent is available or not, there is always an authentic life narrative possible, and who the person is or was. The law is very clear, the bottom line, and ethics and morality is the very complex and necessary miasma which permeates all discussions around the person in the context of law. Now, the components of all our lives, birth, life, dying, and death, and why we feel ill or well, and why illness or wellness is a concept different from disease, whether we have a neurological disorder or not. These are basically the four elements that interact, whether they are wind, earth, water, and fire. And you can attribute each of these domains differently at different times, but they're all essential and they all interplay. Now, definitions. I think it is very important to spend some time on defining what it is, what you and I agree is palliative care. And I won't go through each of these definitions, but there has been a need to try and simplify, at the risk of oversimplifying, what palliative care is. The most important thing is that it is generally a condition where cure may not be possible, disease modification might be possible, and symptomatic treatment is a hallmark of management in this condition. Gold stars for those who can guess this person straight away. She is one of my heroines, and that is Dame Cicely Saunders. And you will see from this collage of images I've put through from Google, her qualifications were very simply MBBS, a doctor, SRN, she was a nurse, and she was also a social worker, a completely unknown entity in today's medical field. A little bit of her history. You can see from her titles and her qualifications that these were earned, and she was a nurse, she was a doctor, and she contributed enormously to the hospice movement. So, born in 1918, more than 100 years ago, married late in her 60s, and died relatively recently in 2005. Once again, she made dying, death, and the application and use of morphine socially and medically acceptable. Morphine is either to be feared or to be used too liberally, and she used science, the art, and compassion in doing what was necessary. She refused to accept that nothing more could be done for people dying of cancer, but equally she redefined the term, what do you mean by doing everything? And we are constantly asked at the coalface by family, parents, please do everything, doctor. What do you mean by everything? Everything must include managing dying and death and good palliative care. Latin, to cloak, to encompass, to cocoon. It's an interdisciplinary, multi-agency approach. So straight away, it is no longer something one person can practice. The agency might be through yourself, the moral agency might be through yourself, but you are acting as part of a larger system, a network. It aims to improve the quality of life of patients and their families by facing problems, having first identified them, associated with life-threatening illnesses and the relief of suffering. It's not just pain, it's suffering, with early identification, assessment, and treatment as possible. It can start at birth. You must remember that palliative care can start at birth and is associated with a normal life expectancy. Frequently at nursing handovers, you hear somebody is ill and therefore palliative care. It basically means that there is a disconnect between what is the actual concept of palliative care and the actual process being engaged in for that particular patient. It is appropriate at any age, any stage of disease, or any prognosis. Now, what do we mean by palliative care? What is our take on it? First of all, it is a philosophy of care which can be exercised at different locations: an acute hospital, an intensive care unit, a hospice, which is traditionally the view, or on a post-acute rehabilitation ward. Similarly, palliative care for neurological disorders should place the central focus on helping patients and their families lead a good life, having a good life till you die. And it is a continuum. So it's very important to take these definitions away. And there's one thing you can take away from this talk is it is using the correct terminology, because this bedevils good research and international cohesion. So palliative care from early in the course of an illness, as I said, from very early in life, of a condition or an illness that isn't really curative or modifiable. So it can start a long, long time before you die. End-of-life care, on the other hand, is approximately the last year to 18 months of life. And terminal care, or the care of the dying person, is in the last few hours, days, or a few weeks of death, of life. This is a standard approach in most of the textbooks, and it just fleshes out what is meant in each of these domains. So concentric circles of terminal care, the smaller element proportionately, end-of-life care, larger than terminal care, but of course the overarching cocooning concept of palliative care. Okay. Now, the conventional model is that you aggressively treat something, and then finally, when the treatment doesn't work, you drop off a cliff edge, and then calls for palliative care or phone calls are made in a hurry, in a crisis. And as we all know, the best plans are made if there is anticipation. So certainly the improved model is to be followed. And this comes from Lynn Adamson in the early 2000s, has been updated since. So you have a condition, and then there are many processes that occur in parallel. So disease-modifying curative care continues at a great pace, but also quality of life, living well with the disease. And hopefully, you may not die from the condition, but with the condition from a completely unrelated cause. You have to then extend that to beyond death. The National Quality Board, the NHS, living well with death, dying in death is mandatory on this. In other words, bereavement support has to continue long after the event of death. Now, what are these actual diagnoses that contribute to the title of neuropalliation, and how do we deal with them? Remarkable progress has been made in the time since even I started medicine 35 years ago in reducing relapses of multiple sclerosis, functional decline being slowed down by medication for Parkinson's disease, deep brain stimulation, stroke units, thrombolysis. The burden, we can't wish it away. 1/7 of people on the planet have a neurological illness of significance, and 1 in 10 will die from it. Now, most neurological illnesses, as we know, remain incurable. They shorten lifespan, reduce time to dependence, diminish quality of life, and are associated with pain and other biopsychospiritual social factors. And this can go for any organ failure, in terms of heart failure, lung failure, kidney disease, but we shouldn't forget the brain and nervous system as well. Now, when I talk about the brain, I rarely or almost never talk about it in isolation as an organ that is the be-all and end-all of things, because necessary as it is not sufficient for that brain to declare itself with a working mind, to be informed of personhood and all its attributes of autonomy, rational behavior, reasonable behavior, self-recognition over time, and of course that connectedness that exists for all of us to exist in society. So any neurological illness that affects the brain affects all these others without question. Now, what are the patterns of neurological disorders? Because neuropalliation, we've defined it, but what are the conditions within it? And the Long-Term Condition National Service Framework in 2005 in the UK helpfully put these 4 conditions, or 4 states, which are not mutually exclusive, of course. Somebody with multiple sclerosis and progressive disease may have a fall and a traumatic brain injury. But in general, it's helpful to look at sudden onset conditions, intermittent conditions, progressive conditions, and stable conditions. And I mentioned in bold at the bottom, chronic disorders of consciousness, which is an RHN specialism, and which I'll talk about in a little greater detail. Now, each of these conditions in themselves require a separate response. And remember, it is a multi-agency affair in terms of addressing neuropalliation. So the number of agencies and persons involved are huge, but they always start with patient and family. Now, I talked about disorders of consciousness. A prolonged disorder of consciousness is when anybody has remained in a DOC for longer than 28 days. PDOC is a syndrome, in other words, a condition of likes, and you have PDOC-like states. They have similar features, different causes, different outcomes, different trajectories, different persons, and there are different stories associated with each of these injuries. So while we tend to concentrate on the biology of an injury very early on because it is necessary to do so, the biography of the injury becomes equally important. I'm indebted to Professor Rob George for that particular term. We can shift into these states pretty quickly with traumatic brain injury or a cardiac arrest, and this usually results in sudden onset global catastrophic injury, resulting in a disorder of consciousness. Or you can drift into these states where there is time, where a capacitous patient or person in full possession of their faculties drifts into these conditions. We have these diagnoses on site, for example, Huntington's disease, motor neuron disease, and there is a chance. The trajectory is always to the left, interrupted by acute exacerbations or periods of feeling fine, but the drift is invariably towards death and an outcome that can be anticipated and planned for. Now, how is this managed in the system after enumerating all these diseases? Quality requirement 9 of the NSF for long-term conditions in 2005 spoke about palliative care. So this is where it all fits in the fish diagram. Now, Hospice UK has also talked about rehabilitative palliative care. Palliative care is not a one-way street. It is not a ticket to the last chance saloon. It is not about a very quick death. It is about managing symptoms and enhancing the quality of life. And therefore, there has to be an element of rehabilitation possible in that formula. So it's all about optimizing function. It is about being holistic. It is about being realistic. And it's about living fully while dying in a new state of life before death. And neuropalliation is no different from any of the other conditions. Now, in 2008, and I should refer to that in the later slide, the Royal College of Physicians, the National Association of Palliative Care, got together, and the BSRM as well, the British Society of Rehabilitation Medicine, to see where our 3 specialties overlapped. And clearly, this is a Venn diagram of those situations, and there is an interface. So it is necessary to acquire the skills sometimes of another specialism to be able to practice it in your own. And I'll talk about these later in models of care. Now, once you have a diagnosis, what about the prognosis or the future? And how could we plan a response? Now, it's important to look at these 3 common trajectories. These are all population trajectories, not just those with a neurological diagnosis. So you have malignancy at the very top, where function is preserved till pretty late in the course of a condition, and then there's a rapid decline and death. It occurs over a shorter period of time. Obviously, that's a generalization. There are different malignancies, occur at different ages. Some are more violent and virulent than others. And the second trajectory is one of a chronic decline with exacerbations, and where your next baseline is slightly lower where you started off from. Most heart failure, lung failure, kidney dialysis or periods of dialysis, depending on resources in third world countries, less developed countries. and finally resulting in death, which might occur precipitously. And finally, you have a functional decline that starts at a very low baseline anyway, and this can come on from different frailty models, as we'll discuss, but mainly frailty, comorbidities, and dementia. I must point out here that when you are dealing with 70 or more patients in prolonged disorders of consciousness in chronic vegetative and minimally conscious states, that line is even lower. It's almost approaching zero. So there's sometimes no function at all in any of our patients. So it is just above baseline where people are, it's a non-progressive condition, but not an unchanging one. Now these explain a little more colorfully, I think, the same aspect, but these are trajectories over time. Always remember, it's a trajectory and a direction of travel that dictates quite a lot of the decision-making and prognosis. This highlights exactly what I said earlier about there being an even lower baseline for those in chronic disorders of consciousness. Now, just as examples for completion's sake, I've taken a table from a publication recently, 2019, talking about motor neuron disease, the vast majority AML and ALS, a rapid or prolonged decline. And as you can straight away see, the rapid or prolonged. I mean, which one is it? But it could be either. Bulbar MND, of course, would have a much more rapid decline. Brain tumors, stroke, multiple sclerosis, and these are generalizations. In the individual person, they could be quite different. Now, once we have diagnosed and given our prognoses, which should be reviewed from time to time, recognizing the need for expert and experienced palliation. Experience in the condition does not translate as expertise. There's a lot of work to be done. And we were hopefully doing a lot of that over here. So I talked about frailty earlier. Is there one tool that can recognize somebody who is on a particular trajectory? And I think frailty is an important syndrome. It's a multidimensional syndrome characterized by loss of physiological and cognitive reserve that heightens your vulnerability. It's a very general statement, but most good statements are quite general. And then it goes on to say how an interplay of multiple interrelated physiological systems and homeostasis fail, and stability of various systems within the human body undergo a sort of disintegration. Sometimes with a rapid decline, other times it could happen episodically. Now, while it's necessary for a formulation at the end of life and to recognize that the body is a finite structure with exhausted physiology at some time and an inability to compensate, that in itself does not define frailty or dying. The person in whom this theater of strained physiology happens is really critical, and while we cannot and we do not ignore the biology of a condition, we sometimes fail to engage persons and families in realistic discussions. We must not avoid considering discussions which might be difficult sometimes in order to write the complete story. Now, there are two major frailty models. One is the phenotype model. I used this on my mother recently, and I said, the little old lady phenotype model, and she said, what is that? What's that about? And I said, frailty. She said, I'm not frail. And then I tried different words, and nothing worked for her. She's 90 plus. And it is the phenotype model of somebody with weakness, a loss of weight, poor grip strength, sarcopenia or loss of muscle for no particular reason, and just a failure to thrive. Somebody whom you know is not doing well. And then there's the cumulative deficits model, sometimes additive, sometimes multiplied, and you look at the interplay of those factors. So a long list of risk factors doesn't necessarily result in a frail person, but should one of them be engaged, like in a cardiovascular event or a brain event, then the others, there's a knock-on effect quite quickly, and they accumulate their deficits and render you frail pretty quickly. So a good 90-year-old might become a very poor 90-year-old fairly quickly. We cannot forget frailty in the young. We always think of frailty as being something associated with older people and an aged, stooped person with gnarled hands walking around. Frailty in the young, almost all our patients on this site are below the age of 75, 80, and the vast majority are below the age of 50. So frailty in the young is hugely important and cannot be ignored. Now, once we have some pointers towards frailty, towards somebody in need of palliation with a neurological diagnosis, what sort of discussions should we be having? And I think if there's one slide to take away from this entire talk, it is this one. And that is to be clear about terminology. Have no confusion of what you mean by saying palliative care, what you mean by saying end-of-life care or terminal care. Okay? And while we always know what, when, how, and where we do a particular task, and that's our specialty, it is absolutely important to know whom we do it for and why are we doing something, or why shouldn't we be doing something. This is very, very important in terms of discussions and outcomes. Now, what qualities do we need to have these conversations and discussions? Okay, certainly competency. It is entirely up to me to keep myself competent. If I am found to be incompetent, I deserve to be censured. It is mandatory. Confidence, that comes, or maybe it's there, it needs to be uncovered, it needs to be supported. And just to say that competency without confidence is quite sterile. It's useless. Confidence without competency could be dangerous. What we have in spades, of course, and all of us in the clinical specialties, is compassion. And compassion, I've just spent a little time, reams have been written on this, and it's good to look it up, but it is not just being kind. It is about doing the right thing at the right time. It's about using your moral agency to open up discussions and go down alleyways that are difficult to go down. And it is about feeling somebody's pain, being empathetic, but having a duty to do something about it. We're not all born with compassion. You would think that a profession would automatically attract compassion, but compassion can be developed further. And I often refer to the 5 C's, which is having a competent, confident, compassionate, and courageous conversation with family. This is not a gallant, horse-charging courage, but a subtle, sophisticated, nuanced, sensitive discussion. Now, serious illness conversations, what are the windows of opportunity? When do we have these discussions? At the time of diagnosis? At the time when something goes wrong? At the time some member in the family has a sentinel event, somebody's been diagnosed with Huntington's disease, do you immediately descend on the rest of the family to have them all tested? How do you do it? But these are an inexhaustive list of how and where they could be done. Hospitalizations, unintentional weight loss, and a failure to thrive, if I recollect what I've just said. Cognitive changes, frequent falls. Walking is said to be a series of controlled falls. We all challenge gravity, everything goes south. But an established marker of mobility, especially the older person, falls. Development of a serious comorbidity, not a cough or a cold, a serious comorbidity. And a change in functional status. We must use appropriate scales. Clinical frailty scores are all very well, but they have to be used for the condition they were developed in. I put in the role of COVID-19 over here in terms of having serious illness conversations and windows of opportunity. And I think that the opportunity, I do not celebrate COVID, but the opportunities provided by COVID to sometimes peg an important, very long delayed discussion have been so many, too many to mention. They've been difficult conversations, but society as a whole has realized what this pandemic did to each of us and about decisions that really should have been made. So if you look at the numbers of wills being made, the number of attorneys for health and welfare being registered with the Office of the Public Guardian, there's a 6 to 9 month backlog for that. And then, of course, the here and now, how do we make decisions for our patients in terms of their treatment escalation plans, in terms of their transfer status? Do we keep them on site? We're a community-based site. Do we transfer them to the acute hospital? We might have wanted to, but the acute hospitals could not or would not accept patients. So that then changes your treatment escalation plan, it changes the nature of your discussions, and also looking at it positively, using a phrase I borrowed from Jenny and Celia Kitzinger, is using windows of opportunity. Now, nothing, of course, can work with the evidence that comes from the science, the art that comes from the application of this science. And a few examples I'd suggest would be something we're all familiar with, guidelines, reams of it, that we need to follow. Some are protocols, most are guidelines, and might apply to most of your patients most of the time. Now, the next 6 slides, I'm not going to dwell on excessively, just to say that we're looking towards excellence. We're looking towards the pursuit of holistic and good patient care. And one tool out there is we use with our palliative care colleagues the gold standard framework, or the GSF. And I'll just put down what does gold actually mean, and what are all these conditions. Now, each of the neurological conditions I mentioned could easily be slotted into an element or more than one element of a biopsychospiritual social model. This is the only model to be mentioned. The biomedical model is mentioned to be condemned. You have to look at it in its entirety. Once you have a neuro-palliative condition, they could be stable, could be unstable, they could deteriorate, there could be an active dying phase from which you pull back from, in which case you go back into a deteriorating, unstable, or even, dare I say, stable phase. And then finally, death must be acknowledged as the point at which all these things come together, and then bereavement support thereafter. So I'll just read the titles out of the next 6 slides, and that is, they're helpfully all with the same logo on them. Research is absolutely important. I cannot emphasize further about using the correct terminology. Why is it needed? That's the fact that we even have to ask the question seems difficult, but we do need research. It is not just to convince ourselves professionally, but also to convince patients and family as to what is available treatment. Also to convince commissioners that this is the right way to go in providing services. Research is important, there are benefits. No one center sometimes becomes an expert in something. If the pandemic showed us one thing, as does global warming, we are a very small point in space, and we're all connected in some way. Independence has and probably has always been a mirage. Interdependence is probably more right than independence. So the benefits of doing research in neuropalliation or any of the other palliative domains. Now, this can't be overemphasized either, a change in culture. So this would be an important takeaway from this talk as well, in that it is more a psychological and a cultural shift that needs to happen up and down the country in acute care and primary care, in rehabilitation units, as to what is needed to address neuropalliation in its truest sense. And of course, no research or no clinical condition or no intervention can be worth its salt if we do not actually measure outcomes. Sometimes not for the sake of measuring them, but there are good, it's worthy doing outcome measurement in these situations. Now, when palliation alone is not enough, and you might have had an unmodifiable, surgically incurable cause of back pain in your early 20s, and you live with it, you live with pain, learning to function around it for the next 70 years. But at some point, if it's not the back pain that takes you, then something else develops, and you might find that when a smoker, peripheral vascular disease happens, you have to have an amputation, and then suddenly with pain and amputation, mobility becomes impossible. And your function declines, your world diameter shrinks from wanting to travel to base camp to your front door and the local post box. So how do we then recognize these trajectories and when palliation move towards the end of life? Now, once again, the tool to be used, which we use here, once again in cooperation and collaboration with our hospice colleagues at Trinity, is using the surprise question. Would you be surprised if this patient or resident or person died within the next 6 months? And if you were not surprised, or if you would not be surprised, then it is good clinical practice and actually mandated to start what is called an end-of-life care plan. An end-of-life care plan looks at two big components. The first is your preferred places of treatment and the treatment they give you access to. And the second is your preferred place of dying, and obviously then death. So if you remember the initial slides on trajectory, when you have a metastatic stage 4 malignancy like a melanoma in your brain, in your liver, the end is pretty quick. It's not far off. So your certainty is higher. But when you have a neurological disorder, which is non-progressive, but not unchanging, and you grow older with that brain injury in a disorder of consciousness, managing uncertainty becomes the hallmark of that condition. It is perfectly acceptable not to know, or to accept that you do not know, till you're in greater possession of facts, information, time, or discussions with persons related to that patient. So the surprise to, what I'm just going to do is to quickly, sorry, on the slide, so just show you, it's not going to work, okay, but you can click on it on the, some of these slides will be given to you as a handout, not all of them, but click on them and it will be available to you, I mean, and just Google Gold Standards Framework and you come up with a brilliant document that gives you everything in a few pages you need to know about the Gold Standard Framework. Now, evidence, we do pursue evidence. I was reading an article last night upon the illusion of evidence, and I found that quite interesting actually. The absence of evidence of effect is it's not the same, of course, as evidence of absence of effect. And that is a bit of a tongue twister, but not everything comes with an evidence base. And some things have to be researched further, but while you're doing that, you don't neglect treating the condition as best you can with the available evidence till you get it. So each of these links tells you how GSF improves identification of people on a trajectory, improves the uptake and management of advanced care planning, ACP, in different settings, reducing hospitalization, improving coordination of care, and of course, looking at how this translates between various hospital systems and primary care. So, our experiences at Putney, we're about 15 minutes away from the end, so I'll race through these. Our experiences at Putney, the hardest of all, and I'll be upfront about that, and I've mentioned that earlier, is a change in perception, a change in culture, but it is a most worthy pursuit. And over the last eight years or so, when the end-of-life care group formed with 3 persons and has grown to be an end-of-life care committee that is linked with the mortality review committee, there are lots of things happening, as you can see from the list of things, and I won't go through all of them. But what you do have and what you do need is leadership, enthusiasm, skills, time, headspace in which to do this, and a value for all life, and living well until you die. That's the motto. Now, it is necessary for all clinicians to develop generalist palliative care skills and not refer palliative care as some sort of a cloak that comes in and validates your working. Palliative care is thin on the ground. Access to specialist palliative care needs to be so much better. A large percentage of palliative care in this country is run on the back of charity. It is not funded directly by the NHS. Specialist palliative care is what hospices and consultants, my colleagues, provide, but we should all empower ourselves by getting competent and confident in the discharge of generalist palliative care competencies. Mortality review is very important, where it's not just about the cause of death, it's also about the process of dying, overseen by a medical examiner who then talks to the families to find out about the whole process, and a focus on dying as opposed to just death. We hope to improve quality through our Quelker Group Ethics Awareness Days. We've just had Dying Matters Week, and in fact this lecture is in the same month as Dying Matters Week because we couldn't get it in the same week. So this is part of that extended marking of Dying Matters Week. Open lectures, training, undergraduate curricula, contracts and contacts with Trinity Hospice, Royal Trinity Hospice in Clapham, training, clinical nurse specialists. These have happened in recent years, and future feeding plans in terms of somebody with, not a surprise that somebody with Huntington's disease and a bulbar weakness will develop a swallowing difficulty, and therefore a plan on feeding has to be made. So future feeding plans developed by our specialist and super specialist therapists here. Local initiative, the Red Bag, in other words, what it is about me that other people need to know. So this Red Bag, Sutton and Surrey, South London, there's everything from a change of clothing and toothbrush, together with your advanced care plan, your cardiopulmonary resuscitation decision, your contacts, etc. And treatment escalation plans and advanced care plans are dispatched in a single line, but I can tell you they've taken months and years of coming to a point where we were happy with the actual documents, as you can see here. The Quelker Group developed these over the years. Needs review and modification. Came in entirely handy and useful at the time of COVID, electronically. Now, to continue in that vein, I think it's important to have that sophisticated courage to ask realistic and honest questions and provide the same in answers. What is our framework? What is our bedrock? It is the law. While we are personally and professionally guided by codes of practice and our own consciences, it is the law. It is fulfilling the law. What is available in the law to deal with people who may not want to be treated, people who may not want the 47th course of antibiotics in 2 years, persons who do not want all life-saving treatment to continue, whether it be ventilation or nutrition and hydration. That is just a smidgen of recent law, of important and recent law. Establishing nursing and therapy competencies. We're working in collaboration with the Centre for Disorders of Consciousness and their program, and quite a few of our nurses are on the program at the moment, and I think all modules have now been subscribed to in their entirety. So in the absence of consent, it is the giving, it is the starting, it is the restarting, it is the continuing of treatments that I need to be sure that person would have wanted. If I'm sure, then I need to do something about it. If I'm not sure, then I need to take it away and discuss. Either way, these need to be marked with best interest meetings and best interest documentation. So to that end, we have reviewed our policy endorsed by the board, and there's an implementation plan as we speak. There's also a concurrent clinical strategy, and we're looking at national and international examples of good practice, not serving to reinvent the wheel. And we also hope to be a leader, and we hope to have a Neuro-palliation conference sometime in 2023, postponed due to COVID, and we could aspire to gold standard framework accreditation. So in terms of continuing this talk with our colleagues in neurology and palliative care, these are the various models possible. The consultative model, which is what we have at the moment, moving in time towards an integrated model. In fact, it does happen at the moment with visiting consultants and clinical nurse specialists. And then, of course, the holy grail of it all is where we ourselves get trained up to a level of proficiency and expertise, where we do palliative care ourselves as consultants in neurological disability, as teams looking after complex neurological disability. Each of these models are not mutually exclusive and, of course, must be linked to reasonably and wisely to academia and commissioning. So really, in conclusion, I've gone through everything I said I would be doing. If I've left anything out, do let me know.